Hi, this video is a continuation of the newborn video lecture. We're going to be talking more about the assessment and the care of the newborn right at delivery. Two terms that you need to know, caput secundum and cephalohematoma, and molding. So molding is a process where the head changes shape temporarily because of mobility of the skull, sutures in the overlapping of the bones of the skull during a vaginal delivery, so it allows the baby to be delivered. The shape does go back to normal within a few days. Now, caput secundum is this generalized edema that crosses the suture lines, and it's superficial. Long labors, the use of a vacuum device increase the risk for this caput secundum. Swelling is found between the periosteum and the scalp, and we'll talk a little bit more about this in class. But cephalohematoma is a deeper edema that occurs between the skull and the periosteum. It is not interstitial fluid, but it is blood. This is more defined than caput, and because it's specific to a particular bone of the skull, it does not cross over the suture line. You can have both, actually. This takes anywhere from 2 to 8 weeks to resolve rather than 3 to 4 days for caput to resolve. But because there's blood involved and it includes the breakdown of red blood cells, there is an increased risk of hyperbilirubinemia with the cephalohematoma. And again, we'll talk a little bit more about this in class. The next thing I want to talk to you a little bit about is about assessing the newborn. Symmetry is key, especially when we're looking at like the eyes and the ears, the nose, and when you're looking at the extremities. We're also going to be talking a little bit about APGAR scoring and normal vital signs, weight, length, a chest assessment, head, eyes, ears, mouth and neck, abdomen, genitalia, and musculoskeletal. Okay, so for starters, APGAR scoring was devised by Virginia Apgar, who wanted to see how a baby is transitioning, and there's 5 things that we look at. Again, we'll talk about this in class, but there's usually, we assess this at 1 minute, 5 minutes, and if necessary at 10 minutes. And the most you can get is 10, so it's 2 for each of the parameters that it's looking at. And one of the things that we look at is like the appearance. We look at the heart rate. We look at the baby breathing. We look at the tone, and we look at the reflexes. Okay, so the most you can get a 0, 1, or a 2. So the total being 10. Usually babies lose off a point for color because of acrocyanosis, which we had talked about, the blue hands and feet. And this is just kind of like it's subjective, but usually babies that have less than a 6 or a 7, meaning they're having a little bit of, issues with transition. We're going to talk a little bit about vital signs, normal vital signs, heart rate. Your book mentions 120 to 160. Actually, the normal is 110 to 160. It can be a little bit higher if a baby's crying. It could be a little bit lower if a baby is just resting and sleeping. Respirations are 30 to 60. They are irregular. They should be unlabored, and they should be easy. Periods of apnea that are less than 20 seconds is considered normal. The temperature is anywhere from 97.7 to 99.5. We don't do rectal temps. We do axillary temps, and we'll show you the proper way to do an axillary temp. Anything greater than 100.4 is considered febrile process, so less than 100.4 is kind of normal. Okay, we don't do blood pressures, but normal blood pressures would be anywhere from 50 over 30 to 70 over 45. The only time that blood pressures are taken in our area is if there's like maybe a question about some cardiac issues with the baby. Measurements, length is usually 18 to 22 inches. Head circumference is usually 13 to 15 inches. Chest circumference is 12 to 14 inches. And this offers a baseline as the baby grows and in what percentile it is growing and making those mile marks. All right. Some of the things, too, that I'd like you to, when we talk about weight, the weight, AGA is considered average for gestational age. SGA is small for gestational age, and sometimes it's used interchangeably with the term of IUGR, which is intrauterine growth restriction, but that is when babies are in less than the 10th percentile. Large for gestational age is when a baby is greater than the 90th percentile. And there's issues that we have with problems with um, SGA and LGA. So when you have a baby, if a placenta is healthy, which we'll talk a lot about when we talk about antepartum and fetal development, but when you have a baby that's small, you got to ask yourself why. So are the parents small? But what's going on with the placenta that the baby's not growing? So a lot of times there's issues with asphyxia, there's hypothermia issues. Remember, they have to do everything that a term or an average gestational age weight baby does. Hypoglycemia, they may have had meconium in utero and may have swallowed some of that. So sometimes when you have blood, oxygen, and nutrients that are working, there is perfusion because the baby's alive. But you might see a bigger head, a larger chest, a wasted appearance, and like thin extremities. And basically, because what happens is the blood, oxygen, and nutrients is going to the heart, the brain, and the adrenals to keep this pregnancy alive. All right. So there could be issues with birth trauma. There could be issues with hypoglycemia. We have more risk of jaundice. So you might have some problems with preterm labor. There might be some hypoxia issues. LGA on the note is that for whatever reason is these babies are growing bigger. So is mom diabetic? Is there more than one baby? Are they past their due date? Is mom morbidly obese? And those put at increased risk for large for gestational age. Now you could have issues with birth trauma, perinatal asphyxia. Same thing, hypoglycemia, the same thing is because this baby's getting that sugar. Once you cut that cord, that sugar fix is gone. So the weight of the baby really tells us a lot on how the baby is going to transition. So that's one of the things to remember. There is a maneuver that we do. It's called Barlow-Ortolani, and that's where you're checking for hip dysplasia. And we'll demonstrate this in class, but I just want you to be aware of that. There are some other things that you can look at. Some special considerations is soothing the newborn. That's in your book. Swaddling the newborn. There is a video on Moodle for that. Newborn testing. Some of the newborn testing that we do has to do at 24 hours. It's called PKU, and basically that's after 24 hours once food has been initiated. And that does, they poke the baby on the heel and they do these blots, and they send it to the state, and then the state sends it to the pediatrician, and it checks a plethora of different types of metabolic disorders that the baby could have. All babies are screened for hearing. If they have an abnormal test, they'll try to redo it. If not, if they get the same result, then they would actually refer them to an audiologist. The biggest thing is maintaining the baby's airway. So again, remember they have that fluid-filled, pulmonary circuit. So you want to learn how to make sure you know how to do a bulb syringe. You want to make sure that we're keeping the baby in a neutral thermal environment. So not too hot, not too cold. Make sure that you're assessing the APGAR scores. We're going to talk a lot about safety at our clinical orientation, about ID bands and HUGS tags. Medications that you will be given in the clinical area include vitamin K, which is an IM injection to the baby. Usually we give it in the anterior thigh, and depending on what hospital, it'd be the left or the right. It does matter depending on what hospital you're at, because sometimes they do the vitamin K in the left and then the hepatitis in the right. Okay, erythromycin is an eye ointment that we give to prevent any type of issues if mom has any type of infection coming through the birthing process. Okay, that is that part of it. There's, if you want to look at step-by-step skills on how to give a bath, you may have that opportunity to give a bath, and your instructor is going to help you with that. The only, hepatitis B is the only immunization that is offered to parents in the hospital prior to discharge. It's passed through the blood and sexual contact. Immunity is conferred through a series of 3 vaccinations. They usually give it at birth, 2 months, and at 6 months. However, patients have to sign a consent. They try to give it in the hospital, but if not, they'll probably give it at that first pediatrician appointment, if you so choose at that point. I want you to make sure you look at some of the pictures and read in your book some of the differences between the preterm and the postterm. I highlighted a few things in your PowerPoint where low birth weight, usually for premature babies, minimal sub-Q fat. They may have some fused eyelids depending on how early they are. Thin skin, visible veins, have more vernix, whereas post-term they have less vernix. They have longer nails. Sometimes they have dry, cracked skin, and they may have some vernix, like behind their ears or in their axilla. Um, they one of the things about the post-term is that you worry about hypoxia, you worry about malnutrition, and that's why they don't really want you to go too far past your due date. And we're going to talk a lot about placental function and amniotic fluid function in class. Now, I want to talk about some of the high risk newborns, and we're going to be talking about some of the sexually transmitted diseases. Even though we're going to be talking about that later in the semester and how it affects the pregnancy, this is what it does to the actual newborn. So one of the things that's called TTN is called transient tachypnea of the newborn. Occurs when there's a lot of fluid that is not cried out after delivery. And the biggest risk factor for that is a C-section. Okay, so there would be increased heart rate. There might be a temperature. There's also tachypnea. So again, it's transient tachypnea of the newborn. So sometimes it's self-limiting. It usually resolves itself within 24 hours. Sometimes babies have to go to the special care nursery or the NICU just for supportive environment. They may need like a little bit of oxygen. They may need a warmed environment. And just that neutral thermal environment. Again, C-section is the biggest risk factor because they're not going through the vagina and having a lot of those modes of why a baby would breathe. Meconium aspiration syndrome we don't see it as often anymore. Well, I shouldn't say that because in labor and delivery we don't see that. It's usually after the fact. It's more common in post-term babies. It's more common in babies that have had some issues like with hypoxia. They're usually small for gestational age. It means the placenta is not perfusing appropriately. And low fluid, which is oligohydramnios. So what happens is when the baby, for whatever reason, the baby gets stressed and it has that meconium in utero, the baby swallows it when they're being born. They maybe take that first breath and they may not be as vigorous at delivery, and that meconium gets into their lungs. And they can develop like a severe pneumonia. It could be pretty serious. We will discuss neonatal abstinence syndrome in class because there's quite a bit that we're seeing with that. But we're seeing more and more of that every day. And we will talk again about some of the signs and symptoms of withdrawal that include like a shrill cry. Sometimes they're inconsolable. They may sneeze. They may be sweat. They may constantly like jittery. They may have some tremors. They may be sweating. Again, it's very important to get a really good history of both mom and then to assess the baby afterwards. We use a term called cluster care. So you want to just kind of do everything that you need to do with the baby at one time so that you're not disturbing the baby. And again, assessment is really key. There might be medications such as morphine or methadone that's given to these babies. But we'll talk again more about this in class. Some of the infections, one of the things too about sepsis and GBS, it's really important that you kind of understand that. Remember, we already talked about sepsis. We talked about it, the immune system and the white blood cells are slow travelers. So generalized sepsis, it happens because they can't localize infection. And then GBS is group beta strep, which all moms are tested for this between 35 and 37 weeks. And what that is basically is that all women have strep in their vaginas, and that's help keep the vagina clean. But sometimes there's this clusters of these colonies that is overwhelming as the baby's coming through the birth canal. It could cause a severe, like a meningitis, pneumonia in a baby, and a baby could die. So we have to treat the mom with penicillin. If she's allergic to penicillin, they give something else like vancomycin. But again, you want to make sure that we treat mom during her labor. So you don't want to break her water. You don't really want to induce until she at least tries to get at least 2 doses of penicillin in every 4 hours. Some of the STDs that we see, syphilis is passed to the baby and can result in a stillbirth, prematurity, low birth weight, hydrops fetalis, and screening is part of the prenatal care that you're going to learn about when we talk about antepartum. Most cases result from little to no prenatal care, so we see that. It's passed via the placenta or an infectious chancre. Vertical transmission is possible when the disease is in the primary or secondary stage or a latent period. It is not transmitted in breast milk, so breastfeeding is possible unless she has a chancre on her nipple. The rash is most prominent over the buttocks, back of thighs, the soles of the feet. It's maculopapular with red or pink color initially, and then it fades to like a more darker color. Some babies die, and even with treatment. There are several anomalies associated with congenital syphilis. Prenatal care is so important because penicillin could take care of this. Gonorrhea is the number one reason for newborn blindness, so that's why we use that erythromycin ointment. Chlamydia is the most common infection of STDs. Conjunctivitis and pneumonia are most common complications, but because of the conjunctivitis, the erythromycin helps with that. Herpes is direct transmission. Moms with a history start taking acyclovir about 36 weeks. And this has decreased the transmission. You cannot deliver vaginally if you have active herpes. Women who have intrauterine infection means that the woman probably was infected for the first time during this pregnancy. And that's why we don't do artificial rupture of membranes or internal monitoring if at all possible. There's poor outcomes for a woman who has a primary infection, and they can breastfeed with this. It's just one of the things that why prenatal care is really, really important. Toxoplasmosis is a common protozoan parasite that rarely causes symptoms in a mature immunocompetent host. It's very rare. Pregnant women come in contact with like cat feces or the ingestion of undercooked meat. It passes through the placenta, and most frequently if the first maternal exposure to the pathogen is during pregnancy. Signs and symptoms include like inflammation of the retina, CSF, abnormalities, anemia, seizures, calcifications of the brain, jaundice, fever, liver, and or spleen enlargement. So again, the risk to the fetus depends on the gestational age. The further along, the lower the severity of it is. But if it's untreated in early pregnancy, it usually leads to fetal demise. Could be a lot of issues with sometimes there's later complications with that, and it has a lot to do with the retina. Like there's a chorioretinitis, which could cause like some blindness, intellectual disability, loss of hearing or vision. And they say treatment is about 1 to 2 years depending on the complications and depending on the severity of it. HIV, hepatitis B in the newborn. HIV, basically, according to the World Health Organization, says that you should not breastfeed. Mothers should continue to take their antiretroviral treatment. We'll talk a lot more about this STD when we talk about infections in the pregnancy. However, it depends on where you're at, and it depends on how you got HIV. Okay, but babies who are born to moms who are HIV positive and who have been compliant with their medication often don't convert to HIV positive, where the CD4 counts are not even shown. Hepatitis B happens because of perinatal exposure. Immunizations and HBIC have decreased the transmissions by about 95%. Without it, there's a 90% risk of infection. Neonates don't really show signs of infection. However, they have some elevated liver enzymes. They may develop chronic liver failure, acute hepatitis, cirrhosis. Okay, they can breastfeed. And then the other thing that I wanted to talk about was just about rubella. It's rare in countries that have high immunization rates. Our country only reports a few annually. Maternal fetal transmissions generally occur 5 to 7 days after mom is infected. It attaches to the placenta and damages blood vessels, causing ischemia. The most critical time of transmission is the first 10 weeks of pregnancy. So that's in the critical stage of organogenesis. Symptoms after delivery include cardiac disease as well as cataracts, glaucoma, a lot of issues with the eyes. And then also PDA is the most common cardiac condition. But you might see some CNS abnormalities like microcephaly, intellectual disabilities, and some psychiatric disorders and some delays. So we will cover a lot at class. We're going to do some case studies in class. There's some things that I want to kind of elaborate on in class, but this concludes the video lectures for the newborn.